You ready to get started, everybody?
Rock and roll.
All right. Well, welcome this lovely afternoon. It's the introduction to health equity for the oral health advocates. My name is Tamara Baca. You can call me Tammy, and my pronouns are she and her. I'm a public health dental hygienist, diversity leader, and chair of my community health center's JEDI program. And based on my work, I see firsthand the social determinants of health my patients face on a daily basis. Casey.
Awesome. Thank you, Tammy. My name is Casey Huber. I'm an individual with a passion for health equity and oral health advocacy. Want to be a healing force for the system, for the people that we serve and underserved populations. In my profession, I am an integrated community specialist for a Medicaid health plan specializing in the adult general mental health substance use populations. And I've been really interested in the social determinants of health ever since I started in behavioral health as a crisis peer support back in the day. So I'm also an individual with lived experience with oral health adversity as well as recovery. So thank you for having me.
Hello, everyone. My name is Taryn Wallstead. My pronouns are they and them. I am a registered dental hygienist, and I've worked in both private practice and public health settings for dental hygiene. My current day job is actually unrelated to oral health, at least directly. I'm a health equity coordinator at my local public health department. And so today I'm really excited to bring the experience from both of these fields together to help provide this training. I'll turn it over to Casey for housekeeping.
Right. Thank you, Taryn. So just a little bit of housekeeping before we get started. Please remain on mute unless you are the person speaking. Questions and discussion is welcome in the chat. Remember the human, please. We welcome discussion, and just remember to be respectful, especially in the chat. As far as the continued education, Arizona Oral Health Coalition is a study club and is a legal continuing education provider in Arizona as the CE provider as determined by the Arizona Board of Dental Examiners. So if you're joining us from another state, please double check with your state CE requirements. Tammy?
All right, I get to talk about the learning objectives. Today we're going to define and provide examples of health disparity, health equity, and social determinants of health. We're going to compare individuals and systemic determinants of health. We're going to practice connecting proximal and distal determinants of health to individual oral health status. Identify and prioritize the needs of patients, and finally practice steps to build trust with clients. It's your turn, yeah.
Yes, sorry, the slide was taking a minute. Yes, so to start off, let's define what exactly is a health disparity. So a health disparity is a difference in health status, especially one that's seen as unfair. So that's the basic definition of a health disparity. We're going to revisit it later to intentionally explore a bit more of this definition, but we wanted to provide this one snapshot at first. And especially for our next slide, please. We are going to jump right in and start off with a small little participatory activity. So on this next slide, we're going to use the Zoom annotate feature. And here are the instructions in case you haven't used this feature before. So as you're looking at your screen, on the very top, you should see a little green bar that says you're viewing. It might say Taryn, it might say AZOHC, I'm actually not sure. But you click on the View Options button next to that. And in the window that pops up, there's a button that says Annotate. And that will bring up this toolbar that will let you draw or stamp. You could add text if you want, but we're mainly going to be using the stamp tool or the draw tool. So you can go ahead and give that a little practice right now in the blank area on this slide. Hooray. Oh, beautiful. Nice. Got some artists in here. Awesome. And if you're joining from a device or that doesn't have this setting, or if you're just not familiar or comfortable with it, you'll be able to share in the chat too on the next slide to participate in the activity. Oh, wow, these are beautiful. I'll give a few more moments just to make sure everyone gets a chance to practice the annotate feature. I want to take a screenshot of this, but I don't know if I can. All right, I'm gonna clear the screen in a few seconds. This is a 5-second warning. How do I clear the screen is my question now. I want to clear the whole screen. Oh, bear with me. There we go. Clear all drawing. Sorry, but on the next slide, you'll get another chance. Because on this slide, we have a list of oral health disparities. This is pulled straight from an article by the CDC. I'll share the link afterwards. And it is several examples of existing oral health disparities. Taking a look at this list, try and use that annotate feature again to mark 2 that stand out to you. So I'm not going to read all of them. I'll read a few of them out loud just while you're reading through them. So we have that adults with less than a high school education are almost 3 times as likely to have untreated cavities as adults with at least some college education. Or head and neck cancers are more than twice as common among men than women. So these are examples of health disparities where we see a difference in health outcomes between 2 groups. And if you're using the annotate feature, that is perfect, great work. If you're not comfortable or able to use the annotate feature, you are also welcome to put the numbers in the chat of 2 that are standing out to you. I'll give you a few minutes to read through these and annotate. Right, seeing quite a few stars on number 2. So for children aged 2 to 5 years, about 33% of Mexican American and 28% of non-Hispanic Black children have had cavities compared to 18% of non-Hispanic white children. Yeah, pretty big disparity there. Also, I see a lot of stamps on number 4 that says nearly twice as many non-Hispanic Black or Mexican American adults have untreated cavities as non-Hispanic white adults. And I'll give a few more seconds, add your stamps, your annotations. All right, thank you all. I'm gonna clear the screen in a few second warnings. Thank you all for drawing.
Like you said, Taryn, I wish we could get a screenshot of this. This is some great information to have.
And we can
sec.
send it out. Oh, Tammy's taking the picture.
There you go. I got a picture.
Thanks, Tammy.
I got a picture of the first one too.
Oh, perfect.
Okay, I have.
Yes. So thank you. All right.
Yeah, I have. Hey,
Hi, is someone wanting to
hey,
share?
Someone
or
off,
is it-
someone off mute.
I think Sandy Tesh. Yeah,
Oh.
thank you.
Could have been unintentional. That's all right. All right. So coming back to
Okay.
our definition of health disparities. So when 2 groups experience different outcomes, that's called a health disparity. But where do these disparities come from? So health disparities arise from historic and modern policies, decisions, and systems that do unfair harm to some groups, generally marginalized and racialized groups, and unfairly benefit other groups that occupy positions of relative power in society. So I know that's a lot. Let's break that down a bit. So first, we know that health disparities are not naturally occurring. There's no innate or biological reason that some groups have better oral health than others. There are, of course, sometimes individual or family genetic factors that can be protective or harmful, but on the population level, there's no real differences based on racial category, gender, income level that would explain these disparities. The second point in this definition is that when one group is harmed, another group benefits. So that relationship goes both ways. And then third, these harms and benefits reflect power dynamics that we see in other parts of society. Excuse me. So we see, someone has a lot of resources like wealth or a higher social position. They will have an easier time staying healthy compared to someone without those resources. And that's the disparities are reflecting that. All right, and I will turn it over to Tammy to talk about oral health.
Okay, so I'm off mute. Let me get to my notes here. So let's go back and let's focus on oral health. And I need all the dental professionals that may be out there, and even just the audience, to share in the chat what causes oral health disease or oral disease. So go ahead and start sharing in the chat or shout it out, so we can keep some records here on anybody.
It almost sounds like a trick question, Tammy.
Yeah, what causes oral disease? We all know that. Like soda, lack of home care, bacteria, like that. That's good. What else do we have? Diet, 4OH, habits, okay. Seems like so far that's what we have. Well, we could start talking about them now. There's individual behaviors, is what people said, bacteria and sugar. Yeah, that's for sure. Some people don't brush their teeth twice a day, drink lots of soda, can cause poor oral health. Genetics can also play. Yes, thanks, Chris. Systemic diseases like diabetes and GERD, and medication use, health conditions, like we said, GERD, they're all true, but there's more than that. When we look at oral disease beyond the mouth, we look at what's called the social determinants of health. What are the social determinants of health? Well, social, political, environmental factors that affect someone's health throughout their life. Next slide.
This one's the video. I hope it will work. Patience is appreciated.
What if your drive to the doctor was over 2 hours and the wait was half as long? Would making an appointment be at the top of your to-do list? Suppose you were diagnosed with a chronic condition, but couldn't understand the directions on your prescribed medication. These are some of the challenges surrounding access to healthcare. Access to healthcare refers to the ease that people get the health services they need when they need it. It's associated with multiple social, economic, and environmental circumstances, including gender, income, education, geography, and cultural factors. Take geography, for example. About 20% of the U.S. population live in rural communities, yet less than 10% of physicians practice in these areas. In the UP's Ontonagon County, a rural county of roughly 6,300 residents, there are only 2 mental health providers. Lack of insurance or inadequate coverage is also a significant barrier to accessing healthcare. In 2014, Michigan launched the Healthy Michigan Plan, the state's expanded Medicaid program, which offers a range of health benefits at a low cost. So far, the plan has helped over 700,000 members see a primary care doctor. The bottom line is that timely and affordable healthcare access impacts physical, social, and mental health. And while increasing access is a complex challenge, we know that patient outcomes and life expectancy can be greatly improved by reducing everyday barriers to care.
All right. So I love this slide. So thank you. Thank you for that, Taryn. We'll go on to this next slide. So what causes the causes? right? Social determinants of health. Here we're going to learn about a little bit about, or at least I'd like to share a little bit of my experience with social determinants of health and health-related social needs. So again, when I was in crisis, psychiatric crisis space, worked on a crisis hospital unit, and started learning about the social determinants of health. It was interesting because I would say social determinants of health. I would mention that term, that phrase in conference rooms, and I would get a lot of head nods, and I would get a lot. It became this kind of a buzzword around healthcare regarding whole person health, right? So I started to research it, and most of the research and most of the stuff that I found through research was the public health perspective. So again, unmet social and economic needs an individual experiences that affect their ability to maintain health. Those are the determining factors of a whole person's health status. So we're always searching for that kind of homeostasis, in our whole person care. So I was looking, and on the right, you'll see that public health sort of perspective, where the categories are very broad. The public health perspective tends to be more broad and very high level. Well, what I did was we created another wheel here over through another project I was working on of the health-related social needs, as well as the social determinants of health, which honestly, they're actually the same categories. But the wheel that I created, or that we created, was a little more delineated and more diverse. However, we could break it down even more than this. But I wanted to kind of be able to pull our perspective up from the direct service provider lens to more of a community health lens, somewhere kind of in the sort of the middle of public health and direct service. So
Yeah, Casey, I really appreciate you sharing both of these models. Social determinants of health, it covers so many things. And so these models do a really good job of conceptualizing them into easier to understand categories. And like you said, the public health one is so high level. It's almost, it feels like we can't really act on it sometimes.
right.
So I really appreciate this community health one. It seems a lot more tangible.
Yeah, that's what I was thinking. Like, how can we use this concept in the work that we do every day with the patients that we serve, right? How can we help people? So, and I'll just kind of, the next slide is going to be, it's kind of a little model that we put together, where it talks about how we can actually use these concepts in our day-to-day perspective, our day-to-day work with individuals who are experiencing oral health adversity. So up here at the top, you'll see the wheel. And I'm just going to kind of run through this really quick. I have a few minutes set aside for this, but we created this, and this is a really neat kind of example of how we can utilize those things in the wheel, the categories in the wheel, which is access to quality health care, housing, employment, food, spirituality and wellness, legal and justice system involvement, social supports and education, to treat somebody's proximal issue. So we have an individual, we want to treat the whole person, right? Or at least be aware of the whole person. So we're going to be treating a proximal issue. And the issue, this is just an example right now of the next activity, which I'm going to ask for your help in. So the proximal issue for this individual I have chosen, poor frowning face, is emotional instability and substance use. And because I have lived experience with emotional instability, substance use, and working with individuals experiencing emotional instability, what is determining this individual's current status, this proximal issue of emotional instability based on substance use, right? We're going to look at those social determinants of health. And having experienced many individuals who were in crisis and acutely unstable. A lot of times, one of the closest proximal issues, was food insecurity. Because I don't know about you, but when I get hangry, I become a little emotionally unstable anyway, whether I'm using substances or not, but especially if I'm using substances. So we want to look at the cause behind the cause. So why do you think this individual is, what's something behind, if you could pick from the wheel, what would you think that is one of the things that's causing some food insecurity, or at least one of the next determining factors of that food insecurity could be? What I was thinking was housing, because if an individual, doesn't matter if they can go to a food pantry and get healthy food or not, if they don't have a place to put the food, then most likely they're not going to most likely oops, sorry.
No worries.
Still on annotate. So anyway, if they don't have a place to put the food, then they're gonna have that food insecurity. Most individuals that are experiencing acute food insecurity, at least acute enough to make them emotionally unstable, are most likely unhoused. So what's behind the housing? Income. They don't have any jobs. So the individuals is emotionally unstable. They're using substances. They've used substances to the point to where they may have lost their job or have never really gotten a good one anyway. So, we want to look at what are some of those stressors and things that would exacerbate that individual's status to the point to where they would lose their job. Could be something like justice involvement. So if an individual is justice involved, they're on probation or parole, or just participating in risky behaviors, criminal activity and such, they're probably going to get so stressed out that they're going to use more substances. Using more substances causes them to lose their job, lose their house, and then they have no food and they become emotionally unstable. So if we want to look a little farther back behind what causes justice involvement, we might look to things like education. If an individual never got a high school diploma, didn't get that GED, then most likely, they weren't even able to get a bad job. And if they did, it wasn't enough to really support them. So some individuals might think they need to go commit crimes in order to get what they think they need. Because they aren't educated enough to utilize the resources that are at our disposal. So the next thing we want to look at, once we've kind of looked at some of these determining factors, we've gone all the way back to education here. We want to look at some of the health-related social needs. What we're going to do is we're going to go ahead and see if we can prioritize these health-related social needs in an effort to create the most positive distal outcome. And in this case, I would think the most positive distal outcome is emotional stability, recovery, and resiliency. And so if I were to pick from those categories in the wheel above as to what the most pressing need would be, what would help this individual the most, it would be quality healthcare, or access to quality healthcare, because that would feed three birds with one scone, as it were. That would eliminate food insecurity, housing, and the income situation. That's if the person is ready. Of course, we have to meet people where they're at. However, if this person is ready to create, behavior change, life change, whatever it is, if they're ready, then we could refer them to a detox, or at least give them the resources for a detox or a treatment center. And that would really capture a lot of those determining factors. So once this individual gets into treatment, we want to address maybe some of those other stressors in life, like justice compliance. We want to get into treatment or detox. They call their PO and say, hey, I'm in treatment. Please don't take me to jail, whatever it is. I'm working on it. So a lot of times, especially these days, the probation departments and the justice system can be more compassionate than they have been in the past. Sometimes they're not, but at least knowing where they're at in that justice compliance and that legal status would really take a big stressor off an individual who doesn't really know how to cope with stress anyway. So after that, one of the priority needs would definitely probably be social supports. And we want to put social supports such as like intense outpatient treatment, AA meetings, or group therapy, those type of social supports in place, because that's really going to support this individual, because the next need, the next need is going to be housing. So this is really going to support that individual in the in working towards that goal of emotional stability, recovery, and resilience. So you have those social supports in place. Now we want to get on to independent living, or at least semi-independent living. We want to address housing, maybe get them in a sober living house or something like that, or transitional living, Oxford house, whatever it is. Once they have a stable place to live, of course, next we're going to focus on job, income. And, everybody needs a job to kind of support themselves. They have the social supports in place to cope with the stressors that come with having a house and having to support themselves with a job. So once they have all that in place and they're semi-stable, maybe it can go full circle back to education. And this individual can start to, gather some self-esteem, gather some of those tools to become the emotionally stable and resilient individual you see on the screen. So that's just a kind of an example of the next exercise that we're going to do. So we're going to go ahead and go to the mural screen. And on this, I am going to need some audience participation, please. All right, so we're going to do the same thing you just saw and create a pathway of determinants to the and prioritize the social needs, the health-related social needs, to the proximal issue. And we're gonna create that pathway of determinants to the proximal issue and prioritize the needs leading towards the most positive distal outcome for individuals in the dental space. So if you want, feel free to come off chat or come off mute or put in the chat. If you were to look at the proximal issue, which is, oops, I got to stop annotating. I got to go to the mouse. There we go. Okay, if you were to look at the proximal issue, which is experiencing tooth decay or loss, what do you think that, and then pick from the above categories, what do you think we'd have here? What do we have? Food. So somebody says food. Spirituality. Let's see.
Sorry, I didn't know if we were starting with food, or just reading them.
No, I'm sorry. I can't see the chat because I only have my one screen.
I got this. I got the chat up.
Okay,
and,
cool.
And no one has said anything yet. So let me. Education.
So education would be the thing determining the tooth decay. Out of all of those, so we have education. Okay.
Access to care.
Yeah, we have lack of access to care. Access to quality health care seems to be the kind of consensus for the first one.
Yep.
So let's put access to quality health care in that first arrow there. We'll move
employment. Somebody else said employment in the chat.
Okay. Let's look at the second one. And if you guys want to come off mute, feel free. What do you think goes in that second arrow? Food. We have a couple of check marks on food. I like that. I like that annotate feature.
Income's in the Ox and employment.
Income, employment. Okay. All right. And we have housing. Somebody checked on housing as well over there. So if an individual lives in a neighborhood where, where it's really hard to get a job, close to them. And they don't have adequate employment, they may not be able to buy that nutritious food that you need to be able to, eat healthy and have some good dental health.
Yeah, like living in a food desert area,
Right? Living in that
where you're
food
getting all
desert.
you're getting all your food from from fast food or through a convenience store.
Oh yeah, take it from me. I experienced tooth loss. I've had 6 implants in the last 2 years, and I had such tooth loss that my teeth look like checkers, and some of the only things that were comfortable to chew were Jack in the Box hamburgers, really soft, carb-filled, fatty things, greasy things like that. So it wasn't really good for me. And then access to quality healthcare, of course. An individual may not have transportation. If they're living in an underserved neighborhood, lack of employment, they may not be able to get to their appointments on time or at all. So, and I think also education could also be behind all of that too. If we were to add another arrow, I think that education component, somebody put education, is definitely a valid thing. So, because there are statistics that show that individuals who have a high school diploma or less tend to have more dental disparities. So, than other individuals who are more educated, who have that high school diploma or have some college or have actual degrees. So if we were to prioritize, let's look at the health-related social needs. So if we're to prioritize what's the first health-related social need out of these categories, what's the first thing that you think this individual, the frowny face, the individual experiencing tooth decay and loss, would need in order to create that positive distal outcome, which is form, function, and whole body health? Do we have anybody want to come off mute or answer in the chat? Or feel free to use your annotate. Oh, we got employment. They need a job. Awesome. Oh, and then the next one. Oh, it looks like
if their teeth are hurting, how would you get a job first if your teeth don't look good?
Okay.
So
what do you think, Tammy? Should we do social support first and then employment?
Yeah, I think social support needs first.
Okay.
Because you want to try to take them out of pain, right? So
right. And if they don't have a job, they won't have that good dental insurance, right? Or any dental insurance for that matter.
And there was something in the chat that said by Chris that it's a sad fact that the U.S. system, that the insurance is often tied directly to whether or not someone is employed. And employed is the right way that offers those benefits. So employment's
super important. I remember when I was struggling with employment myself and dental adversity at the same time, I would often have to go borrow money from my family to get an extraction because my tooth hurt so bad and I didn't want to pull a molar out myself. So so what do we think the next arrow should be? It looks like someone has already checked neighborhood environment, but access to quality health care looks like, what do we think? Should it be housing? Well, hold on. Before we put housing in there, do we want to housing, neighborhood environment? Do we want to, what does it say in the chat? Do we have anything in the chat as far as
employment, pretty much just employment right now.
Employment. How about for number
and social
3?
Support?
We got social support. So how about for number 3? We got housing and access to quality health care. What do you think?
Yeah.
Out of the 2, what do we want? What do you think, Taryn? You be the tiebreaker.
No, we got some tiebreakers in the chat.
We got a tiebreaker.
We have access to quality dental
Access to
care.
quality
And then we
health
could
care.
top it off with neighborhood and environment.
Bingo. There
Oh,
we go.
true. So there's a point that housing is connected to access to care. You know, it could lead to
Right.
access to care. I think a lot of the people in the chat have discovered how flexible a lot of the social determinants are.
Right. Awesome. Looks like we're at time for this one. So we'll go ahead and move forward. Awesome. Thank you everybody for participating in that. That was the first time we've done this exercise, but we've practiced it a lot. And before we move on, I just want to you know, reiterate how this gives you a snapshot of the whole person, so that hopefully moving forward, whenever you're serving somebody and you're determining causes, that you are able to kind of have the perspective of the whole person, and know that you're not just dealing with someone with tooth decay and loss. You may be dealing with someone who has a lack of access to quality health care, a lack of access to food, employment. But yeah, it's just important so that we have that level of compassion and awareness for individuals who are experiencing disparities outside of just that proximal issue. Sometimes it'll help us to be more compassionate when we're aware, you know? So
Yeah, think about the person when we're treating.
yeah.
Next slide, health equity. Health equity means that all people have a fair and just opportunity to be as healthy as possible. So when we look at something like this, and when there's no disparities, that means that we have what's called health equity. Examples of inequality can be anything from income level, sex, age, disability, sexual orientation, race, ethnicity, religion, and even opportunity. Health equity recognizes that each person has the different circumstances and needs, meaning different groups of people need different resources or opportunities allotted to them to thrive. So that means, you know, some people, because of transportation issues, they need some help with that. Achieving equity often asks us to rethink uniform, one-size-fits-all treatment. It sometimes involves devoting more resources and different resources in communities that face injustice to correct imbalances caused by unfair and unequal treatment. And you could see by the picture, you could tell how it works from inequality to equity. Next slide. What can we do at this point now? Well, so what can we do about health disparities? We can address the causes and we can address the outcomes. It's important to do both because addressing the causes will impact everyone, but it takes a long time. So addressing the causes would be through policy change. And we all know that it takes a while for policy change. Addressing the outcome allows us to help the patient and clients that we interact with in the moment, but it does nothing to prevent it from happening to someone else. Both strategies lead to immediate and sustainable impact. We will recommend and practice some strategies. Next slide, sir.
Yes, so we'll talk about addressing the causes of disparities first. So I have on this slide our definition again, but I've emphasized a different part. So health disparities arise from historic and modern policies, decisions, and systems. So that's why policy change is so important, because changing the policies changes the system, and we're effectively changing the social determinants because it's changing the factors that are affecting someone's health. For example, we could talk about smoking. Smoking, we all know, is not good for oral health. It's not good for overall health. However, the rate of tobacco usage can be affected by policy. So people might be they might be less likely to smoke if there's laws in place that limit smoking in public places, or if there's regulations that change how cigarettes are advertised. That example of advertisement is actually a really good example of a social determinant, So I have two facts on here. The first one is from the Aspire Center, which is a program funded by the National Cancer Institute. They found that tobacco retailers are 5 times more prevalent in lower income areas compared to higher income areas. And then on the right, the Truth Initiative found that cigarette companies market cigarettes more aggressively in predominantly Black neighborhoods. So reflecting on this and thinking about how, being surrounded by places selling tobacco, advertising tobacco, like that might have a totally different impact on you than if you just don't even know where to find cigarettes. You can even find somewhere selling it if you tried. So policy change to limit marketing and sales has been done before to successful outcomes. And it's not always immediately obvious that it promotes good oral health, but it is a indirect and effective way to limit tobacco use and therefore improve oral health. So that's why the coalition really prioritizes policy change and supports policies that will impact oral health. Excuse me. And it does, unfortunately, I do want to add, it does take a long time to achieve the policy change. It can take years or decades, but it's well worth it. Casey, I saw you come off mute. Did you want to plug something?
Oh, no, but I definitely, I'm with you. And that's the reason I really, I joined the coalition, was to participate in that policy change, in some of that higher level, decision making and things, or at least have an influence and learn more about that higher level decision making, so that we can help those marginalized and racialized groups,
Thank you. Oh, actually, I'm turning it over to you to talk about strategies we could do immediately.
Yes. So a lot of people, sometimes we may struggle with clients. We may or may not, have any resources to give them. And so we feel powerless. But honestly, if we see it, if you can take anything away from this presentation, and you come away a little more aware, a little more compassionate for the individuals we're serving, and you don't have any resources to give them to meet those health related social needs, there are some great resources for the state, for the state of Arizona. And I think 211 might be nationwide. I know 988 is, but if you don't know where to turn and you notice someone's struggling and you ask them, hey, what's going on? And you develop that rapport with them, please, don't hesitate to use 211. You can call, you can look it up online. And if the individual's struggling, like with transportation, if someone's missing appointments, there could be lots of reasons, like lack of transportation, reliable transportation, long work hours, they need childcare, etc. Just keep an eye out for resources that'll support your clients. Look at conferences, for organizations that can directly provide some services for health related social needs, or that organization can connect you or connect that person, that client, to those providers. And then, of course, that last bullet point, network. Always build your network, with community organizations, so that you're ready to refer clients, patients, friends, family, yourself, if ever the need arises and you come across somebody who's experiencing one of those disparities. So, Tammy?
All right, so let's start talking about how we're going to build some trust, because lack of trust can be a barrier to care. So I'm going to ask for some participation right now. So in the chat, or even you come off mute if you want. What does a lack of trust look like? Anybody have any? Well, I could start with some. You lack of trust, and what it looks like and sounds like, you just want to take my money. lack of eye contact, right? Last time I went to the dentist, they didn't listen. I'm still in pain. That's a lack of trust, you know, so they're going to come in already with a lack of trust. And what reasons exist for that lack of trust? What is everybody saying? Well, not listening to the patient's needs, making sure that you're not making any assumptions, you know. So how do we build trust? We take steps to building meaningful trust with our patients. So we can go to the next slide because we're going to go more in detail. So when you're trying to build trust, a lot of it has to do with how you're communicating with the individual and the person. You know, a lot of times is you want to come with, like, you know, don't judge them. You know, for whatever reason, this person hasn't been coming to you for the longest time. You know, you don't want to judge, and you want to be empathetic in your approach. You know, if somebody's in a lot of pain, you want to be careful of how you address it. You know, here's a great example. I have a patient that I just saw the other day. He told me he's having mental health issues that are kind of, and that's why he hasn't been brushing his teeth. And he goes, "I'm sorry." And I said, "Oh, it's okay. You're here now. Let's clean your teeth." So, you know, having that kind of approach to an individual, something like that, using open-ended questions. And, you know, what is your favorite open-ended question? Does anybody have one? Let's see in the chat.
Tammy, I appreciate that many members in the chat are sharing some of their strategies that they use as well for building trust.
Oh, yeah.
Yeah,
I was reading through some of them. You also want to discuss dental history and need. So a lot of times people, you know, they don't want to come in and get treated for these very large treatment plans. They want to just work on the tooth that's bothering them because they haven't been able to eat. You know, that's a lot of what we want to do. We want to make sure we address the need of the individual. And then you want to ask about health-related social needs on medical history. So some of that, we do that in the community health centers. You know, it's pretty easy to ask that. But when you're talking about private practice or any other kinds of forms of dental, it's hard to kind of ask those kind of questions. You got to be very careful how you put it into word that you're not offending anybody with that. The one I like the most is always to listen, you know, listen to what your patient's concerns are and experiences. You know, that's the hardest part. Is inherently as humans, we tend to not listen as much as we like to talk, especially, you know, most people, you know, we go to, as hygienists, we talk a lot while our patients have their mouths open, you know, we talk about all kinds of things, but we want to listen to the patient. Like they're like, "Hey, I have 5 kids. I may have great insurance, but I have 5 kids and I can't really afford this," you know, and you give them a $10,000, $20,000 treatment plan. That's not looking at the need of the individual. You're actually saying, "Oh, I'm just looking at the need of myself," you know, and you need to look at your patients. Maybe you have some of those patients that always show up late, you know, maybe they have a job where their boss is just not letting them off work. Understanding that person is going to help you have that motivational, you know, and building trust. Also learn what motivates them. An example is we did a happy hour recently of how do we get a 15-year-old to brush their darn teeth. So some of this stuff I have to motivate them because they're going through school on the internet. They're not going to school in person. And that I see that a lot. So their home habits have changed on how they're brushing their teeth. So how do we motivate them? What do we find that motivating some of them more? So if they play sports, I always say, "Hey, if you take care of your teeth, you're going to be a better athlete because you're not going to have that inflammation in your mouth." You know, just little things like that. And then you want to finally personalize what you're talking about, what your goals are, you know, your patient's goal, align your care to what they really want and their goals and their circumstance. Like I said, you know, I come from a large family. My dad was military. You would think that there was a lot of money, but I don't know how my mom did it when she had 6 kids. You know, we were lucky to go to the dentist once a year. You know, looking at my mom and saying, "Oh yeah, you can afford it." Well, you don't know what's happening in the home life and how many children you have, and you have 6 kids and 3 of them are boys, and they're eating like $300 a sitting, of food, So you always have to look at something like that, and then you want to be accessible to give them, like, you want to give them like instructions and tools to use, and that's a lot of things. I want, like, people to understand that we don't always want to say papilla, or like a PDL, and what's that to that person. We always want to talk to them in a non-clinical level, like, you want to get the bugs off your teeth, you want to talk, you always want to give them an opportunity so they understand what you're talking about. And translation is a huge thing. If you have a Spanish speaking patient and they're coming into your practice or anything, and you are not talking to them or giving your treatment plan in Spanish through a translator, that can be actually problematic for you. So making sure that instructions work to ideal for the client and the patient, and you'll be able to work better with that. Also, I work in community health. We get grants for toothbrushes and toothpaste and floss, but there's so many like samples and coupons out there that you can get for a patient. Like Sensodyne gives out free samples that I give to patients, and Sensodyne, if is like almost $12 a tube. On a person that has a family, it's very expensive. So giving them a little sample of Sensodyne can do wonders for you, and they really appreciate it. So building trust to me is one of the biggest things that we need to do as we move forward in the dental community. Any questions? No?
I'm gonna read our conclusion slide very quick, just because I know we're getting towards the end of our time, but questions are still welcome to come in the chat, and we'll open it up to unmuting after I just read the slide very quickly. All right, so we have reached our conclusion. I have a few key things just to hit one more time before we go. So health disparities are unfair differences in health, and we know they are caused by systemic factors. They're not rooted in biology or any innate factors, but we can change them. So policy change can affect the system that causes disparities by affecting the social determinants of health. And we can mitigate current outcomes by building trust with clients and meeting their health-related social needs. Oh, that was actually my last bullet point. I got a little ahead of myself. So I will ask the group, if there's any questions, please do add them in the chat or unmute. And I also welcome you to share after this training today. What is your next step? Is there something that you plan on applying from this training? Is there something you want to learn more about and want some recommendations for resources? Anything like that? I'm going to stop talking and turn it over to the audience.
I really like this, what we're doing here, because one of the things I've noticed in Arizona, and we maybe should have had, is our Black mothers' mortality rate, and a lot of it is tied into the teeth and the mouth, and we're constantly having to, in the public health sector, find money to be able to clean these people's teeth. And a lot of times in public health, our community health centers struggle for funding to be able to even keep their dental program up and running. And that's something that's the trend right now that's kind of going through the states that I've kind of noticed. And it's very sad, because we as healthcare providers, we need to make sure that we are looking at the whole individual when we're treating them,
Thank you for sharing that, Tammy.
You're welcome.
So as far as next steps, I think like one of the things that I've actually made a little headway on with my Medicaid health plan is getting a hold of the dental director and seeing how we can collaborate. And cross collaboration between disciplines. Like I deal with general mental health usually. Those populations I really want to see about cross collaborating with dental professionals, and that's definitely one of the biggest next steps. But yeah, cross collaborating between disciplines has been a big kind of push lately, and maybe doing some provider educations on dental health, like behavioral, creating educational materials for behavioral health providers around dental health and how they can, be more resilient, how they can work with their dental care providers, different resources they can utilize.
Yeah, that's true. I like the collaboration because I don't know when the mouth left the body. It's like, it's crazy. It's like, when did the mouth leave the body? It's just like, the next thing is eye care. Why is it separate from medical care? People can't even get glasses for inexpensive. So, as an advocate for oral health, we need to start looking at everything when it comes to how can we bridge the gap.
Yep.
Mm-hmm.
Do you have any questions from anybody? Don't be shy. Come off mute.
All right. I didn't see any come in the chat, and it sounds a bit quiet. So I want to put the email address up. If anything comes up, please don't hesitate to reach out. And any questions, any ideas, anything at all, I definitely encourage you to reach out. And if you're not subscribed to our newsletter, which I imagine most of you are, that's probably how you found this link. But if you're not subscribed, please find the link for that on our website. It's the best way to keep in the know with all the things AZOHC.
All the things.
All
and
the
thank
things.
you so much.
Yeah, and to let everybody know, I will be at the Western Regional in representation for the Arizona Oral Health Coalition. Stop by and talk to me in person, and so Taryn will also be there too. So we're looking forward to being at the Western Regional, and if you stop by and say hi, I'll give you a free prize.
I just want to thank everyone for carving some time out of your day today to be here with us. We really appreciate it.
Yeah, we do. Thank you.